What's up, beautiful people? Welcome back to a sit-down video finally. My name is Kendra. I am a registered nurse. If you're new here, I started my YouTube channel to tell nursing stories as a way to educate new nurses, nursing students, those of you who are entering the nursing profession. The channel also evolved into me sharing little bits and pieces of my life via my sometimes weekly vlog. I have been a registered nurse now for 13 years. Prior to becoming a registered nurse, I worked as a nurse tech at the bedside. As a matter of fact, I've worked at that same hospital since about 2005, and I currently still work at that same hospital in their float pool. My nursing experience is really colorful. Like, I've worked in a variety of settings. I've worked in med surg, I've done telemetry, I've done step down ICU, I've worked in the ICU, I've also done home care, management and home care, and I've also worked in academia as a clinical instructor. I've also taught in the classroom RN to BSN students, and most recently I became a YouTuber sharing my stories about nursing and creating content to help educate those of you interested in nursing as a profession, those of you currently in nursing school or currently taking prerequisites for nursing school, as well as new nurses. I have been wanting to tell this story here for some time. When I started this YouTube channel initially, my goal was to share stories in an attempt to educate nurses working in the field, specifically new nurses, new grad nurses, and nursing students. I have had certain experiences while working as a nurse, and I've had to make certain mistakes in order to learn. And I always said to myself, if I can share some of these stories to help future nurses or those going into nursing, that is what I want to do. So that way you can learn from errors and mistakes I've made and not do the same thing. Or you can take my stories and apply it when you're working at the bedside, all in the attempt to promote positive patient outcomes. Now, sometimes when I share these stories, I get feedback from people in the comment asking questions or making comments saying things like, oh, you're breaking HIPAA, or you're violating HIPAA, or you're telling this story, are you not afraid of HIPAA? I urge everyone who is concerned about HIPAA to really go back and Google, just a simple Google HIPAA, HIPAA, Health Insurance Portability Accountability Act. Yes, go ahead and Google HIPAA and really read into what that law, what that bill protects, and then you'll have an understanding as to why I am not breaking HIPAA. This story took place about 10 years ago, over 10 years ago, and it has been stuck with me ever since. I was a nurse for approximately 1 year, or maybe 1.5 years. I was a novice nurse, and I know in a previous video I referred to a new nurse or a nurse who had been a nurse for 1.5 years, almost 2 years, as a novice nurse. And a lot of people in the comments were like, oh, well, you shouldn't have referred to her as novice. Novice is the appropriate word to refer to a nurse that has 2 years and under experience. I was a novice nurse. We were all novice nurses at one point. There is nothing wrong with being a novice, okay? It's called crawling before you walk. So being called a novice is not an insult. Me using novice as an adjective to describe a nurse based on her nursing experience, it's not an insult. Me describing a nurse as proficient or expert, it's not at all any way to demean a nurse. If you're 2 years and under, you're a novice, and that is per Dr. Patricia Benner's theory on novice to expert. So that's another thing you all should probably look into aside from HIPAA. I was a novice nurse, and I was off orientation. I was working on my unit, picking up shifts, and if I wanted extra shifts, I would pick up on other units. On this particular day, I picked up on the neuro unit. On this neuro unit, patients are not critically ill. They're pretty much considered med-surg patients. These are patients who have had a recent stroke, but they're recovering, far along in their recovery, or patients who might have been having a really bad migraine or seizures. They're admitted into the hospital, and they're usually put on the neuro unit. On this particular day, I was assigned 5 patients because at the time, yes, med-surg nurses got 5 patients. Now today, occasionally you can go up to 6 patients, but on this particular unit, 5 patients was what I was assigned to on that day. And I got report. Lesson number 1 for new nurses and nursing students: Whenever you receive report from the night shift nurse or the day shift nurse, what that nurse tells you is not gospel. You take everything with a grain of salt. Oftentimes when nurses are giving you a report, they tend to put in their own biases, their own opinions, what they think should happen. And you should, take that in, but also be able to distinguish what is related to you caring for this patient, what is absolutely necessary towards this patient plan of care. You don't take everything in and say it's gospel. You always do your own assessment. You always double check the notes. You always talk to your patient to get their side of what's been going on or how they perceive their care to be progressing. I took a report on this one particular patient, and I was told that she was going to be discharged today. This young lady was somewhere in her 20s, African American or Black, female. She had a very restless, agitated night where she kept asking for pain medicine. The nurse told me, all night I've been giving her Dilaudid. That's all she wants. She just wants the pain medicine because she keeps complaining of a headache, and that is all that she wants. She keeps buzzing the call bell, so she's going to be your problem child today. Now, as a nurse, whenever I get report on a patient, anything negative that nurse tells me about the patient, I put it to the side. Because I'm going to develop my own rapport with the patient, and I'm also going to have a different experience. This has happened time and time again. Very rarely do I receive a patient who I was told was a problem for night shift and they're a problem for me on day shift, because I usually will try my best to turn that around as soon as I enter the room. So I was told she was going to be my difficult patient. Anyway, I got report. And prior to really starting my assessments and giving medications, I start my day off by entering each patient's room, introducing myself, updating the whiteboard once there's a Sharpie, a marker available, updating the whiteboard, checking to see if my patient needs anything, any pain issues, any water, do they need to use the bathroom. I do all of that for the patients before I decide to really comb through the chart and start my day. When I entered this young lady's room, she was awake and she was very restless. And I asked her, hey, I introduced myself. My name is such and such. I'll be your nurse today. How are you feeling? I heard you had a lot of pain overnight. What's going on? And she said, I don't know. My head has just been hurting me over and over. And she's like, I don't know why. So I was like, okay, well, I'm going to talk to the physician's assistant. It's day shift now, so hopefully we can get a better response and, speed things along to find out what's going on. So she's like, please, because my head just hurts. She asked me for pain medicine. So I checked the chart and saw that she was due for pain medicine. So I went ahead, I gave her some Tylenol, and then 30 minutes later, I gave her the IV Dilaudid, which is a narcotic controlled substance. I gave it to her IV. At that time, as a new nurse, I did not know that Dilaudid is not the best option for pain medicine. I learned that later. But as a new nurse, that is what they had been giving her. That is what that's what been ordered. It's what the night shift nurse had been giving her. So I'm just like, okay, I guess this is the routine. We are just rotating Tylenol and Dilaudid. Anyway, I continue on with my day. The young lady kept complaining of headache. I went to the physician's assistant, a couple of times in the morning, like, hey, should we do something? She's complaining of this really bad headache. She's saying it's a 10 out of 10. And they kept telling me, they said, oh no, don't worry about it. We know about it. We think that we think that she's drug seeking. That's what they said to me. We think that she's drug seeking. We're just waiting on our attendant physician to come in and we're going to go ahead and discharge her. And I was like, okay. So because I am a new nurse and because I am a novice nurse, the level of advocacy, I had not yet mastered how to properly advocate for my patients. And this is something new nurses run into often. We don't know how to stand up and speak up for our patients because we are still learning. Our voices and our knowledge is not yet as developed as a nurse that is not a novice. So I was just like, oh, okay. What I would do though is every time I assessed the patient, every time I gave her pain medicine, every time she complained to me, I would go and I would write a note in the chart, like, this is what's going on. This is my intervention. This is what I did extra. Notify the PAs, had a verbal conversation with the PAs, physician's assistant. That's what I mean when I say PAs. And I would just write the response. And I was constantly checking on her because I was just worried about this young lady. So as the shift continues, it is about now 11, close to 12 o'clock in this morning. This young lady keeps telling me her head, her head, her head. Now she is like from the head of the bed, she changed positions. Now she's lying at the foot of the bed. And as a new nurse, I'm looking at her and I'm like, something is not right. Something is not right. I eventually went to the charge nurse. I explained to the charge nurse what's been going on. The charge nurse is like, yeah, they told me she's going to be discharged today. We're just waiting on the doctor. The charge nurse also had been told about this patient, and she had also been told that the patient is more than likely drug seeking. Come on. Again, she's young, she's black. Of course, she's drug seeking, right? Her pain is definitely non-existent. So I was like, okay. So I did go to the charge nurse, because the chain of command as a nurse working on the floor, if you're having any issues, any concerns, you can address it with the physician. If you feel as if it's not being met, then you go to your charge nurse, right? So I went to the charge nurse. The charge nurse is like, hey, this is what they're saying. So I'm like, okay, well, I guess. So I continue on my day. I checked in on her. She had a visitor at this point in time, and the visitor is asking me what's going on with her. And I'm like, well, she's complaining of a headache. I've been giving her the pain medicine. We're just waiting on the doctor to come because they're going to discharge her home. Even at this point, like, I'm listening to myself now as I'm repeating, she's having a headache. She's having a headache. She's complaining of a headache. I'm listening to myself now as I'm sharing this story with you. And I'm back in my mind. I'm back at the bedside with this young girl, and I'm thinking, gosh, like right now I'm thinking, you were such a novice. You couldn't even put the pieces together. You couldn't even put the pieces together. And I wasn't putting the pieces together. And this is why I'm sharing stories like this to help future nurses. So I'm like, I don't know, she's going to be discharged later. And the person is like, well, she don't seem like herself. The visitor ended up leaving, and we're back into the same routine. She's tossing in the bed. She's agitated. She's laying at the head of the bed. She's on all fours in the bed. Now, I had gone at this point to the physician's assistant's office at least 8 times. And there were 8 notes written in the chart. Remember, I'm a new nurse, so I am very, I'm very adamant. I'm very overzealous when it comes to writing a note, because, you know, as a nurse, we write notes, and make sure you write your notes to cover yourself. That's what was pounded into me in nursing school. Cover yourself, write your note whenever you do an intervention. If you think it's something serious, if you think your concerns are not taken seriously, write a note to cover yourself. The chart is a legally binding document. Nothing can be removed from the chart, or nothing should be removed from the chart. Like, you cannot tear a paper out of the chart. If a nurse writes a note and the physician reads the note and disagrees with the note, he cannot cross that note out. You cannot take it out of the chart. That is illegal. So I'm like, okay, I wrote my notes. I'm telling them what's going on. Ain't nobody seem to be concerned. But God. But God. So she's at the foot of the bed. And the thing that raised the biggest red flag for me at this point was she had in hair extensions that were bonded in or glued in. And she started removing her hair extensions. Like, she started grabbing, she's like, my head. And she started tearing out the extensions. And that is when I said no. I said, Because when I was younger, would wear bonded in extensions, glued in extensions. And I know there is not a black woman out here that would be inpatient at a hospital that starts ripping her weave out, her glued in weave. Not happening. I was too familiar with that process that I was like, no. Something is wrong with this girl. And yet still, because of my lack of experience, I still did not put the pieces together. Not only did I not put the pieces together, I did not have the voice to properly advocate for her. So I'm looking at her like, nah. This chick pulling her weave out. So I go again to the office, knock the door, and I told them, I said, y'all got to do something. I said, she's in there pulling her hair out. That's how bad her headache is. That's how much she's saying her head hurts. Again, they were like, nothing, no intervention. I left. I walked back to her room. And out of nowhere, guys, I kid you not, like, I'm not trying to be dramatic. I know y'all probably like, all right, girl, tell the story. Because some of y'all in the comments be like, all right, Kendra, you're taking too long to tell the story. But I have to give you the momentum. I have to give you everything that was happening. I'm back in the moment. Out of nowhere, a physician appears. An older white man. and he had a medical student with him, young white lady. They were both wearing lab coats, and I didn't know why. I still don't know why to this day he was seeing my patient. So he goes into the room, he talks to her very briefly, and he immediately walks back out. And he said to me, "Are you her nurse?" Because I was so concerned about her falling out of that bed. I had parked my computer directly in front of her room. Like, I was watching her like a hawk, because she was so restless. I thought she was going to be on the floor. So he comes to me and he was like, "Hi." He didn't even introduce himself, but he said to me, "Hi." And I looked at his coat and I read Dr. Such and Such. Sorry, y'all. As usual, the camera was like, "Okay, girl, you talking too much and I'm hot. I need to cool down." But anyway, so I looked at his white coat and I was like, okay, he's a doctor. I still can't remember what specialty he was from, but he was definitely consulting on her. And he asked me, he was like, "Has she been like this all day?" And I was like, "Yes, doctor, she has actually." And I kind of gave him a brief synopsis of what's been going on. And I told him I had gone to the physician's assistant. I spoke with the charge nurse about her condition, and I've complained, and I'm really myself, like, I'm concerned about her. He said, "Okay." He's like, "Thank you." He said, "I'm going to go. Where's the physicians?" He's like, "Where do they sit?" So that also now tells me that he doesn't consult very often. He doesn't come to the hospital very often. And it was really weird because it was a Saturday, it was in the afternoon, and he had a med student with him. Or maybe she was a physician that was training. Like, I don't know. I was still a new nurse, okay? So I'm like, now that I think back about it, I was like, that was God. God sent that man because God knew, girl, you are completely missing it. But I'm going to let you slide because you're new. You went to your charge nurse who's more experienced than you. You've been going to the providers who's more experienced than you. Somebody should have picked it up because you're trying. You're doing the very best that you could. And I honestly was, okay? I honestly was. So don't come for me in the comments. But anyway, he said, "I'm going to go talk to them." So he goes, knocks the door, showed him where it is, and he has a conversation. He was like, "Yeah, you know, I'm here to see her." He didn't even tell them who he was. He's like, "Oh, you know, I was here passing through." And he's like, "I just thought I'll stop by and I see her. She's a patient of mine and she's not herself." He's like, "She's in the bed. She's tossing all over. The nurse has been giving her pain medicine. The nurse is literally outside of her room watching her. And yeah, I think you all need to order a head CT, CAT scan of the brain." So they were like, "Oh, okay, remember now, it's a group of physicians assistant. He's a physician, so obviously he has more authority." And so they were like, "Oh, okay." They go ahead and they ordered a CAT scan of the brain for this patient. Usually on a med-surg unit, we don't have to travel off the floor with the patient. The patient's not monitored. They're not on any cardiac drips, any kind of sedation. They're awake. They're not attached to anything. They can go by themselves for testing. But this young lady was so wild. When the transporter came with the stretcher and we had to move her from the bed to the stretcher, I said to him, "I'm going to come with you," because I was afraid that she would be on the floor. I was too afraid she would jump off of the stretcher. That's how restless and agitated she was. So I told the nurse who was covering for me, who would cover for me, that, "Listen, I'm going down for a CAT scan. I have to travel with this young lady in the transporter. I'm just thinking it's not going to be safe for him to go by himself." Got into the elevator. We bring her down to CAT scan. They put her into the machine. And while we're getting her over on the table for her to go in the scanner, the CAT scan tech is asking me, he was like, "She been like this all day? How you been, how you able to care for her and do your job and take care of the other patients?" I was like, "I couldn't. I'm late on all my other meds. She has taken up," this is like now 2 o'clock in the afternoon. I said, "She has taken up my entire morning, an entire early afternoon. I haven't even gone to lunch yet." So we put her in the scanner, and as soon as he puts her in, he comes out, pulls up the stuff on the computer, and he's like, "That explains it. She's bleeding in her brain." And I was like, now mind you, never once did it ever dawn on me that this girl was having a brain bleed. Number one, the med-surg unit I'm staffed to dealt with respiratory, pulmonary issues, infectious disease. Primarily, those were the patients I would care for. On this particular day, I was working on a neuro unit. The fact that I had a patient that was bleeding in her brain and it was missed all the previous shift all night, and then of all the things that could have gone wrong, because that is a very serious, life-threatening, possible life-changing issue. The girl has been bleeding in her brain. Now, mind you, when I got report on her, they told me she had been restless the entire night, meaning how long has this brain bleed been happening? So as soon as he saw that, he calls upstairs to the team and he's like, listen, we have a brain bleed down here. Within 3 minutes, 4 physician's assistants, they're downstairs with me at the scanner. Talking about, well, what's been going on? How much Dilaudid did you give her? I said, let me tell y'all something right now. Look in her chart. I said the chart is right there because when we took her off the floor to CAT scan, I traveled with the chart. I was like, look at her chart. I can't even tell you how many times I gave her Dilaudid off the top of my head. I said every time I gave her a dose, it's documented. I was like, every time I gave her Tylenol, it's documented. Every time I came to you all, it's documented. So look in the chart. And I did not write in black ink. On that particular day, I wrote in this pretty blue ink that was eye-catching. My handwriting was very legible. I write neatly when I'm in the chart especially. So I'm like, y'all can read the notes because at this point we need to get her back in the bed. Back in the stretcher and up to the floor. So everyone is panicking. So they're like helping me get her over. We transport her back upstairs. We put her back in the bed. They started going onto the computers, ordering a bunch of labs, ordering this, ordering that, because you know why? She was getting ready to go to the OR. By the time they came downstairs, when they heard that she'd been bleeding, they already called the attendant physician and was like, yo, we got a problem. We got a huge problem. The attendant physician was already on his way in. He told them, prep her for the OR. Get her ready for the OR because I'm going to have to open up her brain. Another piece of the story. Remember I told you guys earlier on, she had a family member that was visiting. I don't want to give the relation of the family member because that might be too much of a giveaway. But when the family member came and saw how she had been behaving, they left and they went home to tell the rest of the family. Like, they didn't live too far from the hospital. Family member left and went home and was telling mom, dad, everybody else, like, yo, she in the hospital and this is what's happening. So by the time I came back up from the scanner with the PAs helping me, the physician is on his way in. I think as a matter of fact, I think when I got on the floor and I put her back in the bed, when I came out the room, he was already walking up the hallway, suited up. Like, nah, bro, you're going to have to take that suit off and put on your OR scrubs because, okay? When I got back up to the room with the patient, her family members, 6 of them, were waiting in her room. And the reason why they were there is because the visitor who was there earlier, like I said, went home and complained. So they were like, nah, we're going up there. It was deep, okay? 6 of them was in the room. And when we walked in, the PAs was like, the attendant physician's coming in and he's explaining to the mom. He was like, yeah, this is what's going on. We just did the scan and we found that she's bleeding in the brain. The visitor that was there earlier said, see, I told y'all. She was like, I was here. The nurse kept telling y'all. The nurse came to y'all when I was here. And she told y'all something was wrong with her. Something was wrong with her. And y'all wasn't listening. And I was like, thank you, God, for at least having a family member there witnessing my diligence. Thank you, God, for me being prudent enough to document all of my interventions, to document every single time I thought something was wrong. I would write a note. Every time I went to the physician's assistants, I would write a note. Because as a little girl growing up, and even in nursing school, like growing up, my uncle always told me, he said, don't ever depend on your memory. Your memory will always fail you. He said, write things down. In nursing school, they stressed us, progress note, write narrative notes, write it down, okay? Cover yourself. And that's exactly what happened. But the most important takeaways, there's a few takeaways. All of them are important, as a matter of fact. I won't pinpoint any one specific thing. Is that as a novice nurse, when you are new, you don't know a lot. It took me about 2 years as a nurse to be comfortable, even having dialogue with physicians about my patient's condition. 2 years to start being comfortable. I still wasn't fully because I was still learning. Nursing is not about how well you do in nursing school. Nursing is not about, oh, I have all A's in my classes and I got this and I got that. Nursing is about experience. That is why even if you graduate from a community college or you graduate from a 4-year university, a new nurse is a new nurse is a new nurse. a novice nurse. That's what a new nurse is, a novice. We do not have the experience to draw and pull together. We don't have the level of advocacy experienced nurses have on how to go and say, you know what, this is what needs to happen. This is what needs to happen. Telling providers, hey, this is what I'm seeing. You need to come. You guys need to do this. I didn't know how to do any of that. And new nurses are not going to know how to do any of that. Not unless we keep sharing stories like these and encouraging new nurses, hey, this is how you go up the chain of command. When I went to the charge nurse, and the charge nurse was kind of giving me the same feedback that the PAs were giving me, I didn't know at that point there's a house supervisor I could have called. So now you know the charge nurse doesn't know what to do. Call the house supervisor. There's always a nursing house supervisor that oversees the hospital on the days that you're there. Even if you have to go into the chart and find the attending physician, if you think something is going on with the patient and no one is taking your concerns seriously, part of advocacy is doing whatever it takes to get this patient help. And I didn't have, not only did I not really have the training, because I never experienced anything like that in my nursing training, even as a new nurse on orientation, I never had no situation where nobody was listening to my concerns. But I guess as a nurse, at some point, you're gonna have to experience certain things in order to grow and in order to learn. And that's exactly what happened with me in that situation. And this story, I share it every single time I teach a clinical group. I've shared this story so many times because I want for nurses to understand, like, you do have a voice. You do have a voice, and you have to know how to advocate for your patient. It is a very important role in nursing, is advocacy. It is the most important role, is advocating for your patient. Because when the patient doesn't have a voice, they depend on you. You're the one that's supposed to say, hey, nope, this is not going to happen, or hey, he or she needs this. So I ended up working the patient up. And when I say working the patient up, I mean I drew labs, I had to do an EKG, and all of this had to be done quickly. You know why? Time is of the essence. We needed to get this girl to the OR. I don't know what became of the patient, because once the patient left my care and went to the OR, more than likely she got transferred to the ICU. And there is not, I often think of her because I don't know. And I can only hope that her prognosis was good. I only hope that, her life has been spared and has been preserved to where today she's living a productive life. That's my only hope, because I don't even remember her name. Like, I don't remember anything about her. I just remember this story. And I'm also thankful for God showing up in so many different ways. I had a patient one time, he told me, and I'll share this story another time. The line that he said to me have stuck with me. He said, God always sends somebody. And that is so true. God always sends somebody, because if that doctor had not shown up with his med student or his resident, whoever that was with him, I don't know what would have happened to that young lady. I don't know. It was that doctor that went and said, don't worry, I'll go talk to them. And it was because of him we were able to get things in motion, because trust me, I had no clue. I wrapped the video up and then I remembered, girl, you did not even really give any context as to what was going on with the patient. So basically, and this is for new nurses and for nursing students, if you're caring for a patient and the patient is exhibiting bizarre behavior, the patient is having changes in mental status where it's causing you to think like, something is up, something is wrong, question what's going on with that patient. Usually it's because there is something neurologically going on. You have to establish what your patient's baseline is. And that is something I learned in my nursing career. When I got report from the night shift nurse, I didn't really establish a baseline from what that nurse knew that patient's normal to be. I was just told, hey, this is how she's been acting. This is the reason why we just need pain medicine. So as a nurse, when you're new, there are going to be certain questions that you would not think to ask simply because you just have not been practicing long enough. I should have asked now that I think back about it, a question I should have asked was, well, what is her baseline? When did all of this start? Did they do a head CT? But remember, I was a novice nurse. Novice nurses don't have the full insight. We're just tunneled like this. We don't see the bigger picture as new nurses. And that's another reason why I want to do this channel. Now, a change in neurological status is very, Very important. It is not something that should be taken lightly. In her situation, they were taking it very lightly. When a patient complains of a headache, and this might even be a question on the NCLEX, when the patient is complaining of a headache, the worst pain ever, and even though she was saying to me, my pain is a 10 out of 10, I should have known that's probably the worst pain she's ever felt. Along with the fact that she had been restless, she's agitated, she's moving from the head of the bed to the foot of the bed, she started pulling her hair out. Those were all of the clinical signs that something is dangerously wrong. A lot of times, patients are not going to exhibit the same signs and symptoms you have read in your textbook. Her pulling her hair out, that registered with me because I'm black, she's black. I've worn bonded in weaves. She's having a weave that's bonded in and she's pulling it out. I knew that I would have never pulled out my weave, especially in public in a hospital. The fact that she went to that extent, that triggered for me, something is wrong. But I did not know how to properly advocate for her. Whenever your patient is having a change in neurological status, you have to act fast, okay? Which is the reason why it is always important as a nurse to establish a baseline. If the patient's not able to explain to you what their baseline is, and there aren't any family members around, the doctors can't tell you what their baseline, is usually, it's okay to find the number in the chart and call the family members and say, hey, what is this patient's baseline? Or ask, how is she usually when she's at home? I even ask that now when my patients are not having any neurological changes. If I'm caring for an elderly patient, I want to know, what is this patient's daily life like? How are they? Are they up, moving? Do they get up, sit up in the chair? Are they a walker? Do they like reading? Do they listen to music? What is the patient's baseline? It's very, very important. That way, when the change is occurring, you as the nurse knows that, wait a minute, this is not the patient's usual baseline. This is definitely a change. For example, if I had this same patient that was restless and agitated, if for whatever reason now she became combative, swinging, hitting at me, that's a change. She's no longer just restless and agitated. She has now become combative. I assumed care of her when she was restless and agitated. Now all of a sudden she becomes somnolent, meaning that she's just laying. She's not much movement isn't going on. She's quiet. I should be concerned because the baseline as to which I received her in, she's no longer like that. So there's a change. And just because it's a quiet change, just because she's presenting quiet, doesn't necessarily mean that it's good. It doesn't necessarily mean that she has calmed down. It means that something further could be happening. Okay, so I just want for you guys to take that as the takeaway lesson if you are a nursing student and a new nurse. Nurses, those of you that are experienced, specifically working with patients who have neurological issues, or just if you've been in a situation and you can share in the comments, please go ahead and do so. Thank you. Anyway, I hope you all enjoyed this story. You guys know I always have a story time. I have more to come, more sit down videos. It's been a while because your girl has been, taking her summer classes and doing all the things. Thank you all for watching. Thank you all for the support. We will chit chat in the comments. See you in another video.